Good morning, everyone. It's Elma de Vries speaking. I will be introducing Maurice Garcia. Prof Garcia, we are so delighted that he's able to join us today. He's a clinical professor of urologic surgery and chief of benign urology at the Department of Urology at Cedars-Sinai Medical Center in Los Angeles. He's a member and educator for WPATH. He's a co-author on WPATH Standards of 8. And yeah, he's got a long CV that I'm not going to talk about everything because we'd rather like to listen to what he's going to share with us about ethics and principlism in gender-affirming care. So over to you, Prof. Garcia.
Thank you so much. It's a great honor to be here today, and I want to thank you and everyone else for the kind invitation. Let me go ahead and share my screen, and I'll launch into my talk. I want to tell you that I'm here. I'm excited to talk about this paper that I co-authored. Let me just find that little button for full screen presentation mode. There we go. Called Principlism and Contemporary Ethical Considerations for Providers of Transgender Health Care. So I look forward to presenting my slides and talk, and then afterwards leaving time. I've left time for questions, so we can enjoy that. I think that's usually the best part of any talk is the discussion. It's relevant just because it's nice to know who's speaking to the audience. I'm a urologist, a professor of urology in Los Angeles. So I live in the United States, and this is where I work. I don't have any disclosures relevant to this presentation. And I'm going to talk about this paper. To give you a brief overview of the discussion, I'm going to talk about the ethical principles and the landscape of transgender healthcare from an ethics standpoint. I'm going to give a brief overview of the article's background and importance, why we wrote it. I'm going to talk about the principles of biomedical ethics. There's 4 of them: autonomy, beneficence, non-maleficence, and justice. I'm going to talk briefly here about the history and current state of transgender healthcare in the United States, recognizing that, of course, it fortunately exists all over the world. But I'll talk about it in my home area. I'm going to talk about the role of the World Professional Association for Transgender Health and the Standards of Care 8, and go over some of the highlights of SOC 8. And try to show how principlism is interwoven throughout the standards of care. And then lastly, I'm going to go over some strategies to improve care to transgender patients, at least surgical care and clinical care where there's discussion. And I'll kind of explain that in a few minutes when I get into it, so that our care better aligns with the 4 ethical principles. So here's a kind of a screenshot of our title page of our paper, Principlism and Contemporary Ethical Considerations for Providers of Transgender Health Care. The first author is a colleague of mine, Luke Allen. Many of us, of the authors or co-authors, sit on the ethics committee for WPATH. I sit on both the surgery committee and the ethics committee, and these colleagues are great, and Luke really spearheaded the paper and put an enormous amount of work into it. So let's talk about principlism. What on earth is it? It's at first it looks like a typo for principalism, but it's not. It's principlism. And principlism, what it is, it's a framework for making ethical decisions in healthcare based on the 4 key ethical principles, and those are autonomy, beneficence, non-maleficence, and justice. These are the 4 pillars of medical ethics. Autonomy is respect for the patient's decision-making authority, and for the patient's values and preferences. and how decision-making is based on the patient's own values and preferences. Beneficence is acting in the best interest of the patient. Non-maleficence is to do no harm, that is to provide care while minimizing harm to the patient in the course of providing care. And lastly, justice refers to fair and equitable access to care for all, for people. And it's important to balance these principles in many of the complex clinical decisions that we all encounter, whether we're surgeons or mental health providers or primary care providers or social workers, et cetera, et cetera. Autonomy in transgender healthcare is very important. It's a key sort of concept. Autonomy in gender self-determination, or autonomy is a theme of gender self-determination and of the informed consent process, which we all have to face when providing care. We seek and obtain informed consent. Autonomy is present and important in many of the challenges with respect to respecting a patient's autonomy. That is navigating decisions involving minors, cognitive capacity, and then providing mental health to patients. Autonomy is relevant with respect to the unique ethical issues around patient autonomy in gender-affirming care. I'd also add that we should consider autonomy in the frame of transgender health. There's autonomy for the provider as well. Providers can and should be able to say no to providing care that they feel violates their own ethical principles. And this is, I can relate to this one very personally, specifically, the ethical principle of non-maleficence. We don't want to harm patients. And sometimes in the course of care, being providers, we feel an obligation, in fact, a mandate to provide care. But patient's judgment is not always, it's not always, as good as it should be. And they may ask for care when they're not really ready for it, a surgery when their diabetes isn't sufficiently well controlled, or when their weight makes it a much riskier endeavor. And, providers like me can feel conflict about, on the one hand, of course, I want to serve the patient, but on the other hand, I don't want to be part of harming the patient. So, how we declare that in the course of care, our own autonomy, and how we navigate it is, it can be a challenge. Let's talk about beneficence and non-maleficence. Beneficence is an ethical principle present in when we provide gender-affirming care as a means of improving mental health and well-being. We provide care to help patients, in a holistic sense, their well-being, and then to help their mental health, not just their X, Y, or Z function, whether it's sexual function with some of the surgeries that I do, but it's improving, the quality of life for the whole person. Non-maleficence comes into play in ethical considerations where we think of delaying or withholding care, as I was just talking about autonomy. For example, in the context of discussing risks of regret or harm, risk of harm of a medical or surgical intervention. And this non-maleficence, the ethical principle of non-maleficence, is often paired with and presents itself in the same frame as the ethical principle of beneficence. It's in the course of providing care and being, advancing good for the patient, that we also there can be a tension with non-maleficence. We also don't want to harm them, as I was talking about earlier when I was talking about autonomy. Beneficence and maleficence also come into play when balancing benefits and harms in clinical decision-making. Other examples include BMI restrictions for some gender-affirming surgeries, waiting for diabetes to be controlled, withholding care or delaying care until people are stably housed, or that, their medical or mental health or substance abuse conditions have improved, to make it a healthier, safer endeavor for the patient. Justice and equity to access in transgender healthcare come into play when we talk about ensuring equitable access to care for marginalized populations, whether these be people that are of a lower socioeconomic status, prisoners, people in foster care, people who don't have the autonomy that many other adults enjoy in this world, or the means that many other people can enjoy. Justice comes into play in, of course, a variety of contexts. These are just some examples to make the point, but sliding scales for low-income patients, things that providers can do to address healthcare disparities. From a very personal standpoint, I think that justice and equity come into play for surgeons when a surgeon like myself asks themselves, is it ethical for me, as one of the only few providers of a specialty service, gender-affirming surgery, for example, to not accept publicly insured public insurance. That is insurance, at least in the United States, we call that. It's insurance provided by the state. Typically and classically, it reimburses the provider much less than private insurance. So, when my whole career has been in academic medicine, but when I left the University of California at San Francisco and moved to my current institution, Cedars-Sinai, I had a lot of trouble with, the fact that, it looked like I was not going to be allowed to take care of patients with public insurance, because my institution, just normally doesn't do that. And I made it clear that it's important to do that, and that we can still make care profitable for the institution, but provide it in a more sort of just and equitable way to the society around us. And I think that's a good example of how this is a tension that many of us can face. There are ethical concerns related to access to care based on financial or social factors. Situations where a population doesn't speak the dominant language in the area, making an effort to provide translators, making an effort to provide providers that accept lower insurance or lower reimbursement, things like that. I'm sure everyone in present has faced this at some point in their career. Common ethical dilemmas involving minors, parental consent, delayed care, withheld care. There are patients who, ask for surgeries that are non-standard and are potentially harmful to them or irreversible, when we don't feel that it's something that they've thought through completely. These are very common ethical dilemmas that we can face. There's controversies around medical interventions, commonly offered ones like puberty blockers for trans or gender nonconforming adolescents, providing them with gender-affirming hormone therapy and surgeries. There are ethical dilemmas with respect to shared decision-making with patients and families. I'm sure everyone present has instances that they can recall. I've been asked to not say certain things in someone's medical record because, they don't want, X, Y, or Z to be known about them or documented. There's lots of situations like this, or not telling a partner or a spouse, or, just all sorts of situations. And we have to balance, the 4 ethical principles to navigate these. Let's switch gears. Before I talk about, so this is what our paper has been about. And the thrust of our paper was, emphasizing and illustrating how these 4 ethical principles are really interwoven throughout are not interwoven, but are present throughout our organized approach to providing healthcare and surgery to transgender people. So what is WPATH and the standards of care? Many of you probably, I mean, there's SPATH, so you know what WPATH is. WPATH is, the World Professional Association for Transgender Health, and it's sort of the sort of mother organization to a lot of our regional, WPATH umbrella organizations like South Africa. South Africa's, I'm helping start Latin America and Caribbean PATH or LACPATH. We have US PATH, there's EPATH, stuff like that. But what does our sort of parent organization do? The WPATH was established in 1979. It was actually originally established in the 1930s as the Harry Benjamin Society. And it was an organized, group organized to provide transgender healthcare to transgender people. In the early and mid 70s, there was a lot of just to provide you with a history of WPATH. There were, at least in the United States, transgender health care and surgery was offered in a lot of institutions at Johns Hopkins, University of California, UCLA here in Los Angeles provided it. And in the mid 70s, it kind of dried up. It started to disappear because there were publications that were very biased research studies that suggested that surgery for transgender people, genital surgery, for example, was not beneficial, was harmful, in fact. And there were publications scientific publications that called into question the rationale for all of this. Are we actually hurting this population more than helping them? And there was a bit of a backlash, and programs started just kind of disappearing. And the Harry Benjamin Society reformed as WPATH, but with a much different mandate, and that is still, of course, providing healthcare to transgender people, but they became much more focused on evidence-based data. The rationale was, if we're going to fight pseudoscience that wants to deny this population care, the only real way to do it is with solid science showing, in fact, the opposite, that it's helpful to people. And from the first iteration of the standards of care, there was a heavy emphasis on citations, on peer-reviewed literature, and so forth. So the standards of care are simply guidelines. They're not laws, or there's no legal mandate or anything like that. They're simply guidelines written by people more expert than anyone else in the field about the care of transgender people, whether it's primary care folks, mental health providers, surgeons, endocrinologists, etc. And they provide guidelines, and the standards of care is an amalgam, not an amalgam, kind of a summary of these guidelines. It's important for people to remember that these are written for a global audience, and the committees that have written these know very well that what may be feasible in Johannesburg may not be feasible in the countryside of South Africa, or in the United States, what may be feasible is not feasible in Russia or Mongolia or other places, societies and geographical locations where there's a lot of more hostility, lack of infrastructure to provide care, and just different social prejudices that can be difficult to overcome. So the guidelines are implicitly flexible. But they're written thoughtfully in as lay language as possible, and they're, again, very well cited. The Standards of Care 8, we published that in 2022. I'm proud to have been one of the many writers or authors of that. And this has been translated into 15 languages, including English. The different languages are on that little inset there on the far right. and more languages are coming. It's a free download, so anyone can download this from wpath.org. And it's just a wonderful document. I'm a surgeon. I'm going to talk a little bit about ethics in the context of surgery without dwelling too much on the surgery itself. The standards of care. I'm also going to talk about innovations and new features and facets to the standards of care. Standards change, terminology changes, so have standards, and the guidelines have changed a little bit, not radically. We now still require for gender-affirming surgery that patients have a diagnosis of gender dysphoria made by 1 to 2 mental health professionals. At least 12 months of social transition, so living full-time and they're identified with gender. It doesn't have to be binary or transgender in that sense, just however the patient identifies and suits them best to live. That's the right way. So at least 12 months of that. We used to require, the guidelines used to recommend 12 months of gender-affirming hormone therapy. Now it's down to 6 months. There was an initial requirement that patients have 2 referral letters from mental health professionals, so being evaluated by 2 independent mental health professionals. That is now changed to just requiring 1 letter from a mental health professional. It was very onerous. Most people aren't under the care of 2 separate mental health providers. And, it's expensive. It's hard to find people to write these letters. And, I'm actually a firm believer that these letters are important to get. Most patients, I acknowledge, don't need them in the sense that they have gender dysphoria. They don't need someone else to say that. But many people have other issues, unstable housing, other mental health issues that are not well controlled, or physical, health issues, physical health issues, medical health issues that aren't well controlled. And, the organization has sort of suggested that the best way is for one mental health provider or a mental health professional to be the not so much the gatekeeper, but the person in charge of summarizing the patient's readiness for surgery and for irreversible treatments. So that is the spirit in which this requirement is made. And I think for some people, it's very important. We want to, again, beneficence and non-maleficence. We don't want to harm people in the course of providing what on the surface looks like beneficial care. And it is, for most people, beneficial care. For some people, when offered at the wrong time or under the wrong circumstances, can be harmful. And that's what we seek to prevent. These letters can be written by a psychologist or a psychiatrist or someone in a master's in family therapy. There's some flexibility, but they have to be mental health providers and not, a surgeon like me or a primary care provider or someone else. Here is a kind of a cover view of the Standards of Care, version 8. These are all the people from all over the world that were co-authors. And I'm going to just talk a little bit about them, because this is sort of where the Standards of Care is where the rubber meets the road, so to speak, in terms of it's a good example of how these 4 ethical principles, of medical ethics, of principlism, really, sort of enter and become interwoven in the fabric of care. So principlism is present throughout the Standards of Care, and that's what I'm going to try to illustrate in the rest of this discussion. They're part of the fabric of all of the recommendations and guidelines in the Standards of Care, and they're really foundational to all of the guidelines. And we thought, Luke Allen and my group, my co-author group, who published this paper that, the title of this talk, we thought it was important to highlight how important ethics is, because it's it gives kind of a reference point to why what we recommend is important. it gives it sort of ethical substance. It's not just important because it's helpful to people's health, but it's also ethical. It's right. And I think, especially in today's political climate all over the world, we have to keep our eye on trying to do the right thing, and we have to have a compass for, I think, for a lot of the good things we try to do. And so this screenshot here is from the Standards of Care 8. We have a page where we kind of highlight a lot of the new sections. And I wanted to just share with you, I think you can glean a theme from the new sections. There's a new section on, so all of the things with green arrows are new chapters in the Standards of Care. There's a new chapter on assessment of adults, assessment of children, and care of children. There's a new chapter on education, a new chapter on eunuchs and non-binary people, and a new chapter on sexual health. And I think, to me, when I sort of looked at this, from afar, it I think reflects kind of an emerging awareness that there's a lot of diversity within transgender healthcare and the transgender community, the gender non-conforming community. It's not just transgender. So our own field is embracing, the inclusivity that we preach. Some of these other groups that, eunuchs and non-binary folks that I don't want to say necessarily marginalized, but we're not talked about as much as quote unquote transgender folks in the context of WPATH. We're recognizing that sexual health is, the theme of the sexual health chapter is just the fact that sexuality is so diverse, that sexual health by necessity is very diverse, and that there's no gold standard or right or wrong. It's all kind of relative. A lot of the care we provide is ultimately relative. This page shows just a very brief synopsis of the different chapters, and I've gone ahead and put a green box around all the new chapters. Fortunately, there's a new chapter on terminology. I think is very helpful. Those of us in this field, we all know that terminology is always changing, and we have to sort of we want to try to stay current with it so that we use words constructively and use respectful language and inclusive language, and language that recognizes people and doesn't marginalize them even unintentionally. So there's a chapter on terminology, there's a chapter on education and the importance of education, at various levels, governmental, social, public welfare. There's a talk about laying groundwork for education to invite, broader and deeper discussion among educators and healthcare professionals. So WPATH strives to bring people together and broaden the discussion. There's a chapter on assessment of adults, providing guidances, assessment and care of adolescents, a chapter on children and their healthcare with respect to hormone management and puberty blockers and psychosocial, mental health care and such. A chapter on non-binary and eunuchs. And then lastly, of course, the chapter 13, the surgery chapter, which I was most involved in. And then a chapter on sexual health, which I've talked about. Ironically, there isn't a chapter on ethics. And we think that one of the reasons we wrote our paper is, my God, the ethics is really part of the whole fabric of the standards of care. There isn't a single chapter that doesn't rely on the 4 ethical principles to justify the recommendations. Not just to justify, but also to articulate how they're helpful. And not harmful, or recognizing when recommendations can be harmful, how to minimize that harm. All of that is ethics, and that's kind of what I mean by where the rubber meets the road. And ironically, we don't have a chapter on ethics, and we're lobbying WPATH leadership to change that in the future. So we wrote our own chapter, literally as a publication, and that's kind of what I passed this to Mershon and other leadership in SPATH before this talk, and hopefully it can be made available to others. It's in the International Journal of Transgender Health. I'm going to just quickly use as an example. I'm not, just because I'm a surgeon, I don't want to only focus on surgery, but I want to use the surgery chapter as an example of how those 4 ethical principles that I started off talking about are really fundamental to the fabric of this entire chapter. So let me just kind of go over them. These are the 13 odd or 14 different recommendations in our chapter. One of them is that we, for the first time, in the surgery chapter, are now talking about setting standards for surgeons. Before it was, if you knew how to provide surgery, that was great. We had so few surgeons. We still don't have an abundance of surgeons, but we have more than before. And we've also recognized that as people get into this field, there's varying degrees of professional training and experience providing these specific surgeries. So now we recommend that surgeons who are going to provide surgeries to gender nonconforming people have training, documented supervision in these procedures, that they maintain an active practice, knowledge, continuing education, and tracking surgical outcomes. So you can start to think, what ethical principle is at play here? Non-maleficence, not harming people in the course of care because of poor training or suboptimal training. Another recommendation is that we recommend surgeons assess gender diverse people for risk factors associated with breast cancer prior to breast augmentation or mastectomy. Again, non-maleficence and beneficence. We recommend that surgeons inform transgender and gender diverse people that are undergoing surgeries about aftercare requirements, getting to the hospital or to the doctor for pre-care and aftercare, making accommodations, making sure that they have funds for medications that they're going to need afterwards, et cetera, et cetera. We want to think for patients so that they get through surgery safely. And I mean, that has beneficence, non-maleficence, it aligns with those ethical principles. Oops. We recommend that surgeons confirm reproductive options have been discussed before doing something irreversible like gonadectomy. Again, non-maleficence. We suggest that surgeons consider offering gonadectomy to patients when there's evidence that they've thrived well with at least 6 months of hormone therapy. Again, helping, there's harm from native hormones, and we just published a paper showing that, patients on feminizing hormones can lower their dose after orchiectomy by about 40%, and that's good for the cardiovascular system. So again, beneficence, non-maleficence. We suggest that, providers talk about, I guess this next one is also on hormone therapy, that they be stable on it. This next one is, that providers take a multidisciplinary approach when possible, especially when caring for some of the most vulnerable subpopulations like adolescents. So multidisciplinary care is a big theme of the Standards of Care 8. And again, why would we strive to offer multidisciplinary care? Simply to provide the best care. The collective perspective of different specialists is, most likely going to be better than the perspective of just one type of specialist for challenging situations. So again, non-maleficence and beneficence. We recommend that surgeons consult a comprehensive multidisciplinary team for patients requesting non-standard surgeries. Same thing as the last one. We suggest that surgeons caring for transgender men who have undergone metoidioplasty or phalloplasty that these patients be encouraged to follow up with a urologist long-term, beneficence and non-maleficence. And then we recommend that surgeons caring for people who've undergone vaginoplasty similarly see someone expert in that care, their surgeon, a gynecologist, or I would say a urologist as well, because there's long-term urinary problems and challenges, but certainly whoever operated on them. And so forth. So you get the theme. There's an appendix in the Standards of Care 8 where we talk about, or in the chapter rather, and just highlighting some of the new changes. Again, 6 months of hormone therapy before proceeding with irreversible genital surgery that includes gonadectomy. And then some guidelines for care of adolescents. For them, we recommend 12 months of hormone therapy before surgery, not 6 months, just because they're younger and more vulnerable. The Standards of Care 8, at least the surgery chapter, I've thought a lot about it. And, I think it's nice to not just talk about the good and the obvious things, but also some of the gaps, some of the challenges. And I think some of the challenges and future directions that we have to, figure out in the future is, how do we implement some of these recommendations? For example, the directive to track outcomes. How do we regulate implementation of these recommendations, such as formal surgical training for people that provide these surgeries, especially when there's a paucity of surgeons willing to do it, let alone well-trained to do it. It becomes harder to say no to people when they want to participate and honestly do help, but maybe they don't have the best training yet. So how do we balance that? How do we ensure that there's continuing education actually happening for providers? How do we track that? And then how do we track outcomes? International, multi-institutional studies, and especially international ones, require effort. One of the unique things about transgender surgery is that, and healthcare is that it, especially surgery though, it doesn't belong to any one discipline. I'd say about 50 to 60% of the providers out there are plastic surgeons for bottom surgery. 40 to 50%, slightly fewer are urologists. A very small minority, but there are some that are gynecologists. But it doesn't belong to any field. And as we know from medicine and any professional organization, one of the important roles that professional organizations fulfill is quality control and setting standards and ensuring that there's an adherence to those standards. If you get sued because you violated the standard of care in your field. And that field, that standard is dictated by your professional organization. So you start to see that without a professional organization that manages, boots on the ground, the actual delivery of care in the field, it becomes, it can be a little less regulated. So I'm going to transition here to some of my own. I'm going to kind of move a little bit away from the paper in the strict sense. I'm not going to just talk about ethical principles, but this is stuff that's very important to me and stuff I've thought about and published about, but it is fundamentally related to the ethical discussion we just had. And again, remember, I'm a surgeon. The problems and the challenges that I see are primarily, a lot of them are rooted in the surgical, world. I love the statement, we don't know what we don't know. It's a little bit of a play on words, but it's very true. We literally don't know what we don't know. I never thought I'd quote Donald Rumsfeld, a not necessarily popular American politician, but I think this quote is attributed to him as well as to Copernicus. Who knows who said it really first, but it's a good thing to think about. The twist that I've taken on this is that, I tell my students, remember, we don't know what we don't know applies to us as providers. We don't know what we don't know about patients' needs and their priorities. Some patients may want a surgery and prioritize, function even at the cost of high complication risks. Other patients may feel the opposite. They prioritize avoiding complications and are okay with a surgery that maybe offers fewer functions, or maybe less aesthetically pleasing, but at least it's simpler and it's not going to give them trouble down the road. Everyone's different. Nothing is right or wrong. Everyone is different. We don't know what we don't know about patients. Patients don't know what they don't know. They don't know what benefits exist, what different surgical options exist that they haven't heard of. So they depend on us to tell them about them. They may not be aware of all the benefits or the downsides to the different surgery options that we are going to offer them. So, they don't know what they don't know. They can't see around corners. And what I've taken from this perspective is an incredible sense of responsibility. As a provider, we have to think about both of these and be humble and think about patients so that we don't harm them. I think the only solution is to help patients choose the best option for themselves. And the only way to do that is to give them as much information as possible so that they can come to their own decision. And then to package that information in a way that's easily digestible for patients. I think it's also very helpful in the mark of a good doctor-patient interaction for the doctor to take what they've learned about this unique individual in front of them and to say, listen, based on what you've shared with me about you as an individual, this option may serve you better or may not serve you as well as this other option. So sort of kind of personalizing the care that we provide. So I like translational research. I spend an hour with all my new surgical patients going over all the options, and it's often a fairly standardized discussion. I cover all the options, the pros, the cons. I ask about the patients, their sexuality, stuff like that. I ask what they do for work. Got a sense of where some of their priorities may be, but I don't make any assumptions. And then I just present my material. Now, studies have shown that patients forget about 60 to 70% of what is discussed with them in your clinic and my clinic and everyone else's clinic. So what I thought to do was to make an audio recording app that audio records the discussion and then emails it before the patient leaves my office to the patient and to myself. This app is HIPAA compliant, so it doesn't save data or send it anywhere other than by email under my own direction. I, as the provider, control the app, so I make sure that they get a copy and I get a copy, and so forth. The app also lets us make attachments, so I have an attachment for different types of surgeries, and I send those to the right patient. If a patient seeking feminizing surgery will get my feminizing surgery attachments together with the audio recording. So this is an attempt at me. Let's think about this in terms of the 4 ethical principles. Respecting patients' autonomy. I want them to decide. I'm not going to decide for them. And I tell them very plainly, I will not decide for you. I can't. I can't tell you what you're going to want for dinner tonight. I can't tell you who you're going to fall in love with. And I can't tell you what the best surgery is. I mean, it's all you. My job instead is to give you as much information as I can to help you reach that decision. So autonomy is sort of at play with this work. Beneficence, helping patients, non-maleficence, helping them avoid harm, choosing the wrong surgery out of ignorance or because we didn't talk about it or they forgot about it, even though we talked about it in clinic. And then justice. I think it's right. I think patients should get as much, they deserve to have as much information as we can give them. So all 4 are covered in that. Here's just some of the data. We asked patients after they got the audio recording how much of the discussion they would have not remembered, or they would have remembered had they not had the audio recording. And they said just only a little above 50%. Scientific studies have found that to be actually lower, more like 40 to 35%. We found out that patients listened to them an average of 2.3 times and shared them with 2.2 people. No one had any issues with it because they understood it was private, and they could hear the recording well. They thought that 62% thought it influenced their surgery decision, and so forth. So patients do listen to these. And then lastly, we looked at, how did this affect how you feel about your decision? And confidence, patients' own confidence in their own treatment choice went up significantly. Their sense of control over their own care went up significantly. We didn't really see any downside. Oh, and also anxiety about decision making went down significantly. These are all good things. Again, all 4 ethical principles, or at least 3 of them, are present, in that sense. So then we also developed a decision-making tool to help patients pick between phalloplasty with urethral lengthening and without. And we listed all the costs and benefits side by side. We played with, conjoint analysis and all these other fancy, really marketing techniques for helping people figure out what they want. But those are typically not for the consumer, they're for the marketer, the manufacturers to figure out. Instead, the decision-making tool that we made is really for the patient, and it lists stuff side by side. If you go to the Apple website and want to buy a phone or a computer, what's the format that Apple uses? And Apple, they're not idiots. They put stuff side by side and let you can toggle with your eyes back and forth. And that's just a nice, easy way of kind of skimming and seeing, this is important to me. Let me see how it compares. This is not important to me. I don't care if it's present or not present in either version. Next. And that's how patients do it, I think. So we've made these. I'd be happy to share these with anyone. You can take a picture of that QR code and you can get a copy of this. But we made, decision-making tables. Sorry, not decision-making. It's a decision-making tool with features about the 2 different surgeries and, the complication risks, the upsides, the downsides, and how they differ for each one at my center. So my complication rates, not the published stuff. Who cares what the complication rates are in England if I'm in Los Angeles and I'm going to provide you surgery in Los Angeles? All that matters is what my complication rates are, the pros and the cons in that context. So we have these for phalloplasty, and then we have a more granular version where we talk about just comparing phalloplasty with urethral lengthening and without urethral lengthening, different domains that are important: sexual function, appearance, urination, stuff like that. And these are enormously helpful. Patients love these, and because it sort of finally makes it simple and graspable. Again, I said earlier, we want to make knowledge digestible for patients. So, here's one for metoidioplasty with and without. So anyway, again, helping people understand all 4 ethical principles are present in that. This I kind of just wanted to include. We looked at the gender of patients' partners and just sort of seeing diversity. Different surgery options tend to be chosen by slightly different populations. So offering more options to patients, I think, is ethical because, it serves more people better. Because if you look in hindsight, again, different subpopulations tend to choose different options with greater predominances. And that's because, they offer different things to different people. So again, I think it's right. Anyway, before we started using our decision-making tool, most patients got the more complex surgery option, phalloplasty with urethral lengthening. After we started using it, the numbers switched. We started getting far fewer choosing the complex version and more people choosing phalloplasty without urethral lengthening, the simpler version. So again, never choosing for people, simply offering it to them. And I think this is proof that, this matters to patients. I think it's important to try to decrease complications. It's ethical to, again, beneficence and non-maleficence. So I'm going to skip this because I'm running out of time, but I've developed a little fanny pack for phalloplasty patients to put their penis in after surgery. We showed that it significantly decreases the stricture rates. I'm not going to get into why, but it does. The weight of the penis hanging down prevents blood flow to part of the urethra. So doing this has been helpful. So people that participate in research that improves outcomes, there's an ethical dimension to that too. It's helping people. Most of us in this conference are in healthcare because for whatever reason, we like helping people. And I think there's an ethical basis for that. We've developed other strategies like helping people, letting men getting phalloplasty choose the shape of the head of their penis. How important is the shape of the head of the penis? I don't know. It's not that important to me, but I know it's important to some patients. So providing a means for them to participate in their own care, to feel heard and respected, it doesn't cost anything to do it, and patients are very satisfied with that. So I'm going to kind of end my talk here. In conclusion, I think the application of principlism in all examples and facets of transgender healthcare is important, and it ensures that the healthcare that we provide is of high quality and meets high ethical standards. And I think that the integration of ethical principles into clinical practice and policy development for transgender care is important. And we wrote our paper because we want to highlight the ethical principles so that we don't forget about them. I think that's a nice kind of simple rationale for it. It's important, so we can't forget about them, and we should always consider whether those ethical principles are being met and how they're being met or not met when there's challenging situations as well, which are part of medicine, part of life, actually. Not everything is simple. So we encourage continuous refinement of ethical thinking in response to evolving medical knowledge and societal changes. So with that, I want to say thank you very much. I'd be happy to take questions now if there's time, if the leaders think it's okay, and if not, people can ask me stuff offline by email. Thank you. I'm going to stop sharing.
Wow, that was stunning.